good morning,
Morning.
Professor Clarence Zon. I'm Enrique Leira from the University of Iowa. I enjoyed your talk. Uh, we are all obviously disappointed about the negative results, but first of all, congratulations for a very well executed academic trial. I wanted to ask you, how do you put these putting these results in context with the distal trial and the escape MIBO? Were there differences in the population of your patients that you would like to highlight as compared with these other two trials?
The protocol are quite similar, but the main difference between distal escape niveau and discount is we only selected very distal occlusion, especially for MCA distal occlusion. We didn't include proximal M2 occlusion, so we wanted only to focus only on very distal occlusion. So we defined the distal M2 above the mid-8 of the insula to be more homogeneous.
And of course, you selected your patients with MRI, is my understanding, right? You have MRI in all your patients. Is that a distinguishing thing from the other trial?
We only included French centers, and in France, the first line imaging technique is MRI. So most of the patients underwent MRI and were selected on MRI.
So one of the concerns we have with these negative results is whether they could have been some selection biases in the sense that perhaps the patients that ended up in any of these three trials may not have been totally represented from the population of MIBO if some of the practitioners felt that the patient needed to be treated. Do you think that is a concern that you have with your trial? And if so, were there like logs of patients that were potentially approached for this trial or potentially eligible to know if there was any selection bias in the population?
There was a potential selection bias when you look at the mean age of the patient in discount and in the two other trials. It's very high average age. In the discount, it was 74 years. So it could be a bias, but
certainly older than the
yeah.
And is there a way to quantify the bias, with logs and to see if how many patients were approached for or potentially eligible for this trial and how many ended up being enrolled?
We didn't analyze so far all the data from discount because I presented only the interim analysis, but we collected all the patients screened and all the patients included. So we will be able to see if some patients were screened and not included, and to see if there was some bias like this. Yes.
I have another question for you about the medical management, right? So I know you probably try to standardize the medical managers as much as possible in both groups, and I know they both were treated with thrombolysis equally and so forth. I wonder if was there a potential for differences in the medical management in an open trial like this in regards to blood pressure management, since the physicians that took care of these patients knew in which group they were. Is that a potential source of biases, or you don't think it would influence these results?
There was no specific recommendation for blood pressure management, for instance, but all the patients were treated with the standard of care in France. So I think it was homogeneous. I don't think it could bring a bias. And regarding thrombolysis, 70% of the patients received IV thrombolysis in both groups. So
excellent. I was also surprised that in this type of surgical or intervention trials, it's not unusual to have crossover of patients to being enrolled and adjudicated to one group and then ended up being in the other group for a variety of reasons. But 22% of the patients assigned to the endovascular group never got the endovascular intervention, right? But 0% of the ones in the medical group switched to endovascular. I was wondering what do you make out of that number? What would be the reasons why these patients didn't end up getting the thrombectomy, and if there was also an analysis per protocol, whether this has been factored and if that had any influence in your results as well?
We gave some strict recommendation to the investigator to avoid as much as possible crossover, especially for the medical group, because it it will bring some bias because the main analysis is an intent to treat analysis, but we also perform a per protocol analysis. But you're right, the rate of crossover in the medical arm was 0, and for the patient in the experimental group who did not receive the thrombectomy, it was because they had a clinical improvement between the randomization and the initiation of the thrombectomy, probably due to the recanalization after the IV thrombolysis.
So, every time there is a negative result in a trial, we ask the investigators, what do you think, why this didn't work? What assumptions of before the trial didn't play out? Was the outcome in the medical treatment better than expected? Was there the complication rates? I know you have like double rate of hemorrhage and mortality in the thrombectomy group. Obviously, they're not statistically significant, but they're double numbers. What do you think play a factor here in not getting the expected result from the assumption?
The results we have tend to show that the thrombectomy could be deleterious compared to medical treatment. So I think distal thrombectomy is not dead after these 3 trials, but maybe we will have to select more the patient, and maybe the device we have, it's the same device as for proximal occlusion, but with smaller sizes. So maybe we have to change, the shape of the device, the paradigm of the devices, and to have new devices very dedicated to distal thrombectomy. And when you look at the topmost study from the German group on PCA occlusion, they showed that overall mechanical thrombectomy was not beneficial for the patient, but when you select patient with a high NIH score or patient who cannot receive IV thrombolysis, thrombectomy was beneficial. So maybe could be the same in the 3 trial presented yesterday.
So we go back historically in thrombectomy, maybe it was a device issue, right? So 77% of the patients assigned to the thrombectomy group, it was not successful, the thrombectomy, right? If I recall correctly.
The rate of recanalization with thrombectomy was 77%, which is lower compared to what we have in proximal occlusion. Usually it's 85 to 90% of recanalization rate.
So you think that gap may be able to be overcome with newer devices?
Yeah, and it was the same for proximal thrombectomy in 2013. 3 randomized trials were negative because in this trial the operator used old devices which are not used anymore. And 2 years after, we had 5 randomized trials, which was the benefit of mechanical thrombectomy. So maybe in 2 years, we will have 5 randomized trials showing the benefit of distal thrombectomy.
So you don't think this is a dead avenue? You think we're going to find a positive trial down the road with a different device?
I don't know. We have to see. We cannot predict the future.
Well, in any ways, congratulations for a well-executed trial, and a pleasure talking with you today.
Thank you very much. Thank you.